So we thought it was important to hear directly from many of the workshop participants, particularly in some of these key research areas, on not only why they see this as the greatest need, but also key research studies that are ongoing or that they would propose to be conducted in each of these areas. So just as a quick introduction, not doing justice to each of these 5 individuals, but in speaking towards priority area number 1, we'll have Dr. Yvonne Nartey from the Cape Coast Teaching Hospital in Ghana, who has been a real leader in operational research for both Hep B and Hep C in Ghana. So welcome, Yvonne. We have Dr. Janus from the University of the Philippines in Manila, who's been conducting operational research around this area of integrating hepatitis B services in primary care. So welcome, Janus. Priority area number 2, we've asked Dr. Gibril and Ndow from the MRC unit, the Gambia, to speak a bit on the operational research for prevention of vertical transmission for hepatitis B, and a real leader in that area. In priority area number 3, honored to have Professor Lewis Roberts from the Mayo Clinic, who has led many networks and collaborations around research for hepatitis B and hepatocellular carcinoma in Ghana and more regionally throughout Africa. So welcome, Lewis. And finally, last but not least, Dr. Hailemichael Desalegn, who many of you know as a real champion for hepatitis elimination globally, as well as in the African region. He's coming to us from St. Paul's Hospital, Millennium Medical College in Addis Ababa, Ethiopia. So thank you all for joining us today. Invite you to come on video so that you can be seen by our audience here. So just welcoming Dr. Lewis, Dr. Gibril, Janus, Dr. Yvonne, and Dr. Hailemichael. And we encourage everybody to put their questions in the Q&A box as well. If we don't get to them verbally, we'll ask our panelists to speak to those. So please address your question in the Q&A to a particular panelist, and we'll have them provide answers as well. So if I could start with the priority area number 1, and maybe I'll kick it off with you, Yvonne. So thank you again for joining, both here in the webinar as well as the workshop last year. And I was wondering if you could kick us off really in speaking to priority area number 1 around decentralizing care, and give us a sense of what we mean by decentralized care in your setting, and why research in this area would be important. What potential impact could research around decentralizing care and simplifying care models actually have in Ghana? Thank you, Yvonne, and over to you.
Thank you, Neil, and thank you for the opportunity to speak as well. So for decentralized care, it's basically shifting care from specialist centers to lower levels of the healthcare system, so primary care, for example, community centers, urban health centers, district or sub-district hospitals. I'll give the example of Ghana, where at the moment hepatitis B care is mostly specialist-led at the larger teaching hospitals. So decentralized care would look at shifting some of the management of these cases to lower levels of the healthcare setting. And I think this is really important, and research in this area is important because we need to generate evidence to be able to influence some of the policies that are made in the country. I think we also need to be able to provide evidence to better plan budgets. For example, at the moment in Ghana, there's not a heavy budget line for hepatitis B care, so generating the evidence would be useful for that. And I think it's also important to help reduce hepatitis B related stigma, because many people who have hepatitis B may be seen at specialist centers in these larger hospitals, and there may be a fear or a misunderstanding associated with the diagnosis. So shifting it to lower level centers makes it seem as though it's more of an everyday or a relatively less serious condition, and there would be less fear, and potentially people would be more likely to get access to care. In terms of what types of operational research would be useful, I think initially starting with evaluation of existing programs, and I can give the example of Ghana, where we did the HEAT project, where we evaluated testing and treatment capacity, and we realized that, again, this care was predominantly in the larger teaching hospitals. So starting that way would help us identify whether there are gaps and where exactly the gaps are, which levels of the healthcare system, so that we know where to focus some of these interventions, some of these strategies to decentralize care and expand care. I think that other studies would look at assessing various implementation strategies, particularly in Ghana. If we look at simplified models of care, that would be very helpful, because we could potentially look at observational or implementation research where we target community health centers, sub-district level health centers, and potentially integrate some of the hepatitis care into pre-existing clinics. It's been spoken about how HIV care services, the continuity of care seems a lot better than hepatitis B. So well-established systems, adding on hepatitis B care, or even looking at antenatal clinics and adding on hepatitis B care through training of the healthcare workers to be able to manage this. So doing implementation research in these would be very useful and would generate very good data or evidence about how decentralized care is important and necessary. We could evaluate or measure the proportion of people who have been diagnosed, how many have been put on treatment, how many have been retained in care in comparison to the pre-intervention state. So yep, I hope that's a bit of a summary of why decentralized care is very important and what kind of research we could do. Thank you.
That was an amazing summary, Yvonne. Thank you so much for that. And maybe here I'll invite Dr. Janus Ong to give us maybe a different perspective, regionally speaking. Janus, you've conducted similar type research in the Philippines and Vietnam. Would love to hear from you, how that some of the operational research questions that you're tackling that you think need to be tackled, and what are some of the challenges that you've had in conducting such research and that you would want to overcome, in the coming year. So thank you, Janus, for your thoughts.
Thank you also for inviting to be a part of this webinar. I think the situation in the Philippines is pretty similar to Ghana, where we really have to generate the evidence base for us to be able to influence policy within the government. I think one of the things that to add to what Yvonne had mentioned, some of the research that we did before we went ahead and co-designed a model of care with key interventions, so a package of interventions. But before we went to that, we did some research, pretty much like what Yvonne said, was to scope the landscape of hepatitis care in the country. And then we also assess the patient journey to get an understanding of the pain points that patients were experiencing in their care, and how a patient-centered, decentralized, and integrated care delivery would be helpful for them. We're now implementing our model of care, but I think the pain points are still there, and we really have to address these pain points, especially with respect to acceptability of screening, both by the patient and the healthcare provider. We also need to go back and really reinforce the treatment eligibility determination. We found that sometimes there are mistakes that are made, and going back and doing it over and over with the healthcare provider through telementoring, I think is very helpful in making sure that we reinforce what they've learned in the training, and also to reinforce the need to adhere to follow up, as well as to the callback for the determination of treatment eligibility.
Thank you. Thanks, Janus. I think that really speaks to some of the challenges that we find operationally for hepatitis B care delivery. How do you, when you are proposing those different interventions, how do you study those? How do you, insert those strategic interventions into the care model and then actually evaluate those? And what has the challenge been around that? I think some of our audience members might be, wondering. It sounds like it's pretty easy to, evaluate an intervention. What makes it so difficult?
Well, I think what makes it difficult is that it's a package of interventions, and so there are many moving parts, and our goal is to look at the cascade of care outcomes mainly, but we have provider and patient surveys both before the start of the model of care and at the end of the model of care. We also did a health facility assessment at the start, and also we're hoping to do it at the end of the 1 year of the trial. The other thing is that we're going to be hopefully, so that this would be really a game changer, would be to really cost out the interventions that we did in order to come up with a cost estimate, which in our country, it's very important to be able to have a package, a benefit package within the health insurance for sustainability mainly. So, the challenges are there, and we conduct quarterly quality reviews, monthly actually, within the countries, and then we're going to do retraining and implementation review every quarter.
Thank you, Janus. Really appreciate it, and walking us through, some of the steps that are needed. Let me pass this over to Gibril. Gibril, you've been conducting, prevention studies and looking at vertical transmission in the Gambia and elsewhere for quite a few years. Can you talk a little bit about what you see for the future? What is the next step that we need to take in vertical transmission research and prevention of vertical transmission in your setting and beyond in the coming years? Thanks. Over to you.
Thank you, Neil. Thanks for inviting us for this. I would just say that elimination of molecular transmission is priority number 2 in this report, but that doesn't mean it's less of a priority than anything else. If anything, I would say it's the number 1 priority, because it's the only way that we can ensure a generation free from hepatitis B moving forward. Over the years, the sad part is prevention of molecular transmission has been neglected in most of the low-income countries, and as a result, it has led to lots of new infections, and we have now realized that infections acquired perinatally from mother to child through molecular infection actually leads to more severe disease in adulthood, accounts for more cases of liver cancer, which have a terribly short survival in most of the low-income countries, where resources needed to manage them are not available usually. In most of our research and our work on implementation of these strategies, 2 things have come out as the most striking problems. And they all center around demand and supply. On the demand side, there is a terribly low demand for the uptake of these strategies that we know we have now. There is maternal testing during pregnancy should be accessible. The test kits are available. as point of care. They are relatively cheap. And there's a vaccine that can prevent chronic infection, and this should normally be available, but there is very low demand for them from the pregnant women, from the community, from the policymakers. And we think this centers around poor community awareness, both from the policymakers, healthcare workers, and women. And on the supply side, there's an ineffective supply chain in the sense that there is no clear pathway to increase the uptake of these strategies within the healthcare systems. And most of them should be relatively easier to implement, but for various reasons, they are not. It doesn't happen. Oh, I thought you had a question there. I thought you were saying something.
No. I was going to say, so those are some of the clear challenges. How do you propose through operational research that we get to some of the solutions?
I think operational research questions centering around increasing awareness and knowledge, increasing community engagement in the prevention, diagnosis, and management of vertical transmission of hepatitis B is a priority. And this is a low-hanging fruit. It's relatively easy to do, it's relatively inexpensive to do, and it would have amazing yield. It would improve political will, it would improve supply of these services, it would increase streamlining and integration of services using resources that we already have. So we just need to increase awareness and find out what would work, what would not work, what is the best way to increase the demand and the adoption of these integrated delivery services. And the other key operational research question I would say is to understand how we can scale up interventions in a differentiated model of care in diverse settings. Yes, we have all of these resources at our disposal, but we do not have the evidence of how to scale these implementation models in diverse settings, from the well-developed urban hospital-based antenatal clinics to the remote rural ANCs that are manned by perhaps one community health nurse with a trekking clinic, and most of the deliveries happen in less medicalized settings. So having an operational research that aims to increase uptake of strategies of PMTCT in decentralized settings can help address some of these questions. And alongside them, we can build in other studies to understand the cascade of care outcomes, the cost effectiveness of the different strategies, and even randomized trials of the effectiveness of different PMTCT prophylaxis strategies. Whether do we have to prophylax all the positive women or only women who are potentially at high risk by virtue of high viral loads? Do we discontinue prophylaxis after delivery, or do we continue it during the reproductive years? And what are the best practices to scale up timely birth dose vaccination, both in facilities and in home deliveries?
That is a great overview, Gibril, because I think you hit on many of the different interventions that were discussed in the workshop, and the research questions that would be associated with each one of those. Wish we could continue this conversation, but for the sake of time, I'm going to move on to Professor Roberts. And thank you, Prof, for joining. And I think you could really speak to any of these key priorities given your experience over time. But we'd love for you to walk us through what you see as in priority area number 3 as some of the new technologies or potential technologies that could really improve hepatitis B care in the African or LMIC settings overall. And what studies do you propose, or would you mentor young researchers to conduct, within their settings to improve hepatitis B care through those technologies? So over to you, Professor Roberts. Thank you.
Thanks, Neil, and thanks for the opportunity to be part of this panel. I think one of the keys really is recognizing for hepatitis B that for many healthcare workers, it's a confusing disease to understand. And that means that for the community, it's a confusing disease because they might go to different healthcare workers and get different messages back. And so if there was a way for us to simplify the testing so that we could identify those people most likely to have progressive disease of some kind from their viral hepatitis, that would be extremely valuable. And of course, that's a global challenge. And I think even in high resource settings, we have difficulty determining that there are a number of new tests that are being brought online, things like the core-related antigen tests that we're really trying to better understand to see if they would give us clues to a person's risk of progression of their liver disease from viral hepatitis B. But it looks as though at this point, we have these algorithms that encompass different elements of the disease. So we look at DNA replication, and we look at the DNA, the HBV DNA levels in the blood. We look at the response by the liver, and we look at ALT levels in the blood. And then we wonder if the inflammation that's reflected by the ALT actually is causing a problem in the liver, and we have tests for fibrosis in the liver. And ultimately, we are looking to determine whether people are at risk for liver cancer, and there, for example, gene variants that they carry that put them at risk. And I'll let Dr. Desalegn talk about, those other aspects. But clearly, a complicated landscape. And then, there's the whole thing of the Delta virus and anti-HDV and the fact that individuals that have Delta virus are at higher risk, for example, of complications. And then there's the broader question about what we would call the exposure, the things that we're exposed to in the environment, things like fungal aflatoxin exposure that also contributes to risk. And we find, I think, particularly in sub-Saharan Africa, that we suspect that many of these factors that are measured really by different tests integrate together potentially to lead to what we see, in practice as a very early age of onset of cancer in persons in sub-Saharan Africa. And so how do we then, in a sense, simplify testing so that, there is either a minimum or an integrated set of tests that can be performed that healthcare workers will understand and be able to interpret, and even more than that, that we will be able to explain in simple ways to not only the people who live in the cities that are educated, but what I call the last mile. And Dr. Ndow was saying, the people that are out, in villages with maybe only basic education. And so the health awareness piece, I think, is critical. And but also in the research area, are there ways that are there innovative ways that we can either develop new tests or simplify the integration of the tests that we have. And of course, that means also figuring out ways to deliver these tests at lower cost so that there's better community awareness of the disease.
Thank you so much, Prof. I think you highlighted not only the innovation aspect, how do you bring these tests online, but then also how do you integrate them in care to really determine, different features or clinical features, epidemiologic features of each individual and their risk of progression. I think that's a perfect setup also for you, Dr. Hailemichael. You've been struggling with this question for many, many years now of who to treat, who in your context is the highest risk, for progression. Can you walk us through what you've proposed or thought about in terms of research and really pooling, a large network of researchers together to determine, cofactors or some of these risk factors that Dr. Lewis was mentioning for progression of disease and to severe outcome. So Hailemichael, over to you. Thank you.
Thanks so much, Neil, for this opportunity and the coalition for the effort and the exercise that we had for this roadmap. So when it comes to the hepatitis B progression to cirrhosis and cancer, just to take you back to our studies, when we do the studies in the hepatitis B cohort in Ethiopia, when we started, we have seen that the guidelines that have been used, for example, doesn't fit for the Ethiopian, and we have seen also for the other African context. When you see the gaps that the study from the consortium by Dr. Lewis has also shown, hepatocellular carcinoma is quite different because it occurs at a younger age, and it was associated with a poor prognosis. So there was no data to inform actually the guidelines in Africa to show which individuals are actually rapidly progressing to cancer. And as has been shown, this could be, as Gibril said, could it be the age at the accusation of the infection, the host factors which occur at different ages? Could it be the hepatitis B genotype by itself, or the environment that could be associated, the nutritional factors, the aflatoxin? So there are a lot of things going on that could lead to the progression of the hepatitis B. And the previous guidelines that we have been extrapolated from the Taiwan, from the reveal studies, were not working for the African context. So what kind of studies can be done to actually reach or to assess the hepatitis B progression? So from the hepatitis B in Ethiopian context, we try to scale it up to some extent in Ethiopia. And we have seen the different kinds of study designs which have been presented by you, Neil, the case control, the cross-sectional studies, which are actually having low impact. But same come with a team, initially with ASCARE, and we have some support to have a longitudinal aggregates of what has been done, like a retrospective and longitudinal data. And if this can be aggregated, can this be like a rapid outcome? Because randomized controlled trial in longitudinal cohort like the reveal may take longer time. So for a short time to start, we have coordinated with that to have the Hepatitis in Africa network. And this probably could help us to gauge some of the outcomes that could help in the progression, or that could lead us into the markers for fibrosis markers for the African context. But these are all like the tip of the iceberg, considering the 3,000 data from the HepSanet or the such collaborative data. So we are proposing to have a better, robust data to have is to establish probably a research centers that could in a long term can liaise with potential collaborators like Professor Lewis having a genetic study. Then we can have collaborators in Africa that could solicit the different ideas, proposals, and also funding probabilities, call for proposals. And then with this team at different centers, we can probably study the different outcomes that I've said that could probably play a role in the progression of the disease. And mind you, as you have said, the clinical trials probably, we have like 2/3 of the new infections for Hep B, but it's 1% from the recent study clinical trials in Africa. So African involvement in these new trials, new studies, unless it has been done with such research center establishment, it will be difficult. So these research centers actually need an equipment, they need an expert. Training is a backbone for all these resource centers, and then supporting the laboratory, the biostatistician, the IT support, and other important infrastructures are also important in the resource centers.
Thank you so much, Haile. I know you could go on for much longer, and I appreciate you introducing those concepts. This has been a really wonderful panel. I wish we could carry this forward, but I think the partners panel that John will facilitate later will touch back on the coalition building and the network building.